How to assess the temporomandibular joint before planning full mouth rehabilitation. Save it, share it. History. The most important first step. Before touching the articulator, clarify whether the patient has a current or a previous TMD history. Ask about preauricular pain or temple pain, clicking, popping, crepitus, episodes of open lock or closed lock, morning stiffness or fatigue, chewing pain, difficulty with wide opening, prior splint therapy, injections, physiotherapy, orthodontics, trauma or surgery, recent change in bite or inability to find the bite. This is the foundation of the DC-TMD pain history approach, and it prevents mistaking a symptomatic unstable system for a routine restorative case. Number 2, access to screening, function and psychosocial load. In large rehabilitation, it is not enough to know whether the joint clicks. You also need to know how much the condition affects the function and whether the patient has high pain-related distress or parafunction loading. The DC-TMD framework includes a psychosocial domain, and tools such as jaw functional limitational scale and oral behavior checklist help quantify mandibular limitation and harmful oral behavior. This is particularly relevant in patients with wear, bruxism, chronic pain, or failed prior dentistry. Next, clinical joint and muscle examination. Your examination should document maximum unassisted and assisted opening, lateral and protrusive movement, pain during opening, closing, lateral excursions, deviation versus deflection, T.M.J pain on lateral pole palpation, muscle tenderness of the masseter, temporalis and related muscles, reproducible joint sounds. This is essentially the clinical core of DC-TMD Axis 1 and remains the best validated framework for chairside diagnosis of common TMDs. Next, determine whether the joint is adapted or active. For FMR planning, the key question is not simply, is there a click? Many patients have signs without major disability, and some asymptomatic individuals show internal derangement on imaging. What matters clinically is whether the joint is comfortable, functional, and stable enough to tolerate irreversible restorative change. Inference. If symptoms are active or function is deteriorating, system should be stabilized before definitive reconstruction. Next, occlusion. Assess it, but do not overblame it. In practice, this means assess the occlusal instability, wear pattern, fremitus, loss of posterior support, guidance schemes, and centric relation maximum intercuspation issues, but do not assume that a full mouth occlusal remake will cure the TMD. Next, imaging. Choose the modality by the suspected problem. Use imaging when your history and examination suggest structural disease or when the findings will change the sequence or extent of rehabilitation. MRI, best for disc displacement, joint effusion, retrodiscal or soft tissue pathology and internal derangement. CBCT, best for osseous morphology and degenerative bony changes, condylar contour loss, erosion, osteophytes, resorption, ankylosis, fracture or other skeletal pathology. The 2023 AAOMR imaging recommendations specifically emphasize that TMJ imaging prescription should be based on patient's complaint history and clinical findings and not routinely ordered for every patient. Next, when to delay definitive full mouth rehabilitation. I would avoid starting definitive FMR immediately when any of the following are present: current joint pain or muscle pain, recent locking, progressive or unexplained bite change, suspected inflammatory or degenerative joint disease, major functional limitation, unresolved parafunctional overload, uncertain mandibular position because of pain avoidance or guarding. In such cases, reversible stabilization, short-term deprogramming or provisionals, and appropriate imaging or referrals are more defensible than jumping into irreversible occlusal reconstruction. That caution is well aligned with systematic reviews showing insufficient evidence to use prosthetic changes as primary TMD therapy. Next, practical FMR endpoint. Before definitive restorative records, you want a comfortable joint and a muscle state, a repeatable mandibular closure pattern, no unresolved acute TMD episode, acceptable functional range, and a prosthetic plan that respects adaptation rather than forcing an unverified mandibular repositioning strategy. This is the safest prosthodontic reading of the current evidence-based. Comment chair side and I will share a simple chair side sequence for you to be used daily in your practice. Don't forget to save it. Don't forget to share it. Let everyone benefit. Take care.